Welcome to this Antimicrobials in Society event. We are just waiting for all the participants to join. I can see the numbers going up at the moment. So welcome. This is our event to launch our report addressing antimicrobial use with 2 roundtables. I'm going to start with some housekeeping while we wait for any additional participants to arrive. So this event will be recorded and will be available on the Antimicrobials in Society website where you registered. And the event is being captured today by an illustrator to create a visual summary. Please use the question and answer function to ask questions of our speakers. And for technical issues, can you please use the chat function and direct your message to Rachel. So we know that 274 people registered for the event today. And I would like to start by finding out where you are all from. I know as a participant, when you join these events, it's all a big blank screen. So it's nice to know who else is on. So what you need to do, and we're going to have 2 polls, so you might as well get onto it, is get out your phone or go online. You have to type in pollev.com/Claire Chandler 814, and then the polls will start arriving onto your device. And for this one, you can zoom in and just drop a pin where you are, and we can then see them all arriving on the screen. Here we go. Rachel, do you want to mute everybody's images from the panels while we're doing this? Oh, this is fantastic. Look at all the pins dropping. People are everywhere. We've got Brazil managing it. That's not very many people in America at this time of the morning over there. But we do have people all the way down in Australia. This is incredible. Fantastic. Well, now you all know that where everybody else is as well. So we are a big group. I can't actually see anymore how many people are here. I don't know how to navigate this in Zoom. I can see more pins dropping, so I'm just going to wait for a couple more seconds while we see them all and get our final results. Look at that, dropping all over. In the sea, someone fell in. Great. Well, welcome to everybody. My name is Claire Chandler. I'm a medical anthropologist at the London School of Hygiene and Tropical Medicine, and I am our director of the Antimicrobial Resistance Centre there. And today we are hosting this event from the Antimicrobials in Society project, which is a research project funded by the Economic and Social Research Council in collaboration with other UK funders. And I'm going to do a second poll now that we have seen what, and that's an amazing range, fantastic. I'm delighted because that is our intention, is to try and give a bit of a global picture. So our second poll is, what's your kind of background, or in what capacity are you joining today? So we might have some social scientists. Forgive me if these are not relevant to you. We do have some others, I'm sorry. It's amazing seeing these dropping in, this is fantastic. Although we don't know the numbers, but we can see the proportions. So we do have quite a few social scientists and other research scientists. Researchers are definitely going to be our majority, I think. and other, I should have put, please specify. It's amazing seeing these move live. So our intention today is to present some findings from research from the social sciences to other researchers and others involved and engaged in programs, policy implementation in relation to antimicrobial resistance, in particular antibiotic use. So we're really kind of trying to communicate with a wider audience today, but it's fantastic that we do have good representation from our community of social scientists in antimicrobial resistance, which is excitingly quite a large community. So welcome to everybody, and thank you very much for participating in the poll. It's great to see the numbers. I'm going to go to the next slide. So antimicrobial resistance, for this audience, I don't believe that I need to give you any spiel about why antimicrobial resistance is important. But I will say that social science within antimicrobial resistance is very important, but seems to be a small subset of research. This was a search run by Marco Hainsgen and his colleagues a couple of years ago now, where they found that social sciences came to less than 1% or about 1% of all of the research articles that were published on antimicrobial resistance. But having said that, the field really is growing quite rapidly. Another paper that was published last year by Liu and colleagues showed really quite a rapid increase in social research on antimicrobial resistance. And within this, antibiotic use is a major topic. And that's where our focus is today, although there is some fantastic and really, really interesting and important work on emergence, transmission, and the burden of AMR from the social sciences. The majority of funded research has been on looking at antibiotic use. So today we really want to launch this report, which has just gone out online today, which provides insights from social research about how to address the increasing and yet uneven use of antibiotics around the world across the One Health spectrum. The schedule for today, so we're in the report launch section right now. We will then have two roundtables. We'll have one which is consideration of this report on the social science aspects of antibiotic use and the recommendations from social science, considerations for research. And the second roundtable will be considerations for policy and programs. We have a short break in between. During the break, you're welcome to watch a short film from one of our studies within Uganda from the AMIS Uganda team, but you can also just take a break. And at the end, we have a Q&A from the audience, so please pop your questions into the Q&A box ready for that. So without further ado, we'll get on with talking about the report. This is the front cover of the report, and you can now download it by clicking on this DOI link, which you can also see through our Twitter feeds and so on. Oh, and if you're going to tweet today, please use the hashtag SocsciAMR, and we can keep things together. So the idea with the report is to respond to the need for a kind of bird's eye conceptual map of the work in the social sciences. So I said the social science research on antibiotic use has really, really increased, in fact, slightly overwhelmingly so. And what does it all mean? At this time point, we are all quite interested in looking at what interventions should we be doing to improve and optimize the use of antibiotics. We know that they're used differently in different places, but how should we be intervening upon that? I'd like to acknowledge at the beginning that there's an enormous community of researchers in antimicrobial resistance from a social science perspective and antibiotic use in particular. Just this small number of 31 researchers plus Alice and I, so 33 of us contributed to this report. And And this really emerges from a very collaborative group of social scientists who have ended up kind of being quite an inspiring community of practice, working on the topic of antibiotic use in lots of different places. And many people contributed to the conceptual work that we present today through participation in our advisory group, through the panel series that we ran last year, and in developing the report. I'd also like to acknowledge our two illustrators who contributed some nice pictures, which you will see in the presentation. The report was funded, and the research that we're doing is funded by the Antimicrobial Resistance Cross-Council Initiative, which was led by the Economic and Social Research Council in the UK in collaboration with Arts and Humanities Research Council and Department of Health and Social Care in the UK government. So what did we do? Well, very briefly, we assembled an advisory group, which was selected. We invited people, in fact, from our Antimicrobials in Society website. We have a list of people who are researchers actively working on antimicrobial resistance around the world. And this is a really useful resource if you're looking for people who are working in this topic. We've tried to encourage lots of people to send us their profiles and their work on AMR so that we can kind of have a point of connection between people. So we invited people to join an advisory group, and then the advisory group helped to set up a panel series which aimed to provide an overview of antibiotic research and its implications for practice across a range of different settings. So we had 4 panels last year. There was also a short online survey of social scientists, a review of publications, conceptual framework, consultation where we sat down with virtually a smaller group from within our advisory group to kind of work through our emerging findings. And then the draft report was circulated to our whole advisory group, and that enormous list of people that you just saw all contributed in some way to these stages. The panels that we did were in 4 different themes. So we had a first panel on antibiotics as care, focusing on health facilities. And then the second one, beyond health facilities, focusing on care, but also thinking about pharmaceuticals and markets in different places. Our third panel was looking at antibiotics beyond humans, so looking at ecologies, productions and flows. And our fourth panel was about antibiotic science, technology and infrastructures. These were really, really fascinating. So if you'd like more detail on what people presented from their own research, you can watch those back on from our website. So our aim with the panels was not to summarize all of the findings on antibiotic use. That would be a huge job and would require separate reviews really for each of these domains. Our focus was to extract the recommendations that social scientists have made from their research, either through piloting things that they'd tried out in practice, observing ongoing interventions, or from their observation of the current situation. So it's the solutions that we were trying to extract and to summarize in our report. So our analysis from all of these different steps of bringing together the panels and the literature from antimicrobial resistance scholars in social scientists, it kind of suggested that there were these 3 overlapping areas in which kind of grouped together the ways that people were thinking about the problem of antibiotic use. So, of course, in all problem solving, the way that we describe a problem impacts the solutions that we will consider. So we have a tendency also, especially if we're pressed for time and resources, to reach for the kind of solutions that we already have available, that we've already perhaps been using before, regardless of whether they necessarily are the right ones for the problem at hand. And the trouble is that antimicrobial resistance is proving to be a hugely challenging set of problems, and antibiotic use within this set of problems has become apparent as a really tricky issue, and it's not been well addressed with the set of solutions that we've had so far. Antibiotic use is increasing in many situations around the world, in humans, animals and in plants. And although in some places there have been some successful reductions, in other places actually still needs to increase where access is poor. Social science is really good at helping us to think about the ways that we're framing our problems and therefore the ways that we frame our solutions. The way that we see a problem affects what we can see as a potential solution. And so our report argues that in order to address the problem of antimicrobial resistance needs different thinking, but also different arrangements to allow for different kinds of interventions. So to look at the recommendations from the different social science studies, we grouped them into these different themes according to the entry point of their definition of the problems and solutions. So I'm going to talk through each of these briefly. They are practices, structures, and networks. This is an illustration to try and portray the practices grouping, in which the majority of social research on antibiotic use has been carried out over the years. And this really focuses on addressing end user antibiotic use. It shows how, and here in the report, we're showing how scholarship has moved away from knowledge deficit models to embracing what might be broadly termed an ecological approach, and to considering practices as embedded in lives and livelihoods. So this body of work emphasizes the centrality of local context to identify possible targets for intervening to change practice. And I would say a major achievement from the social sciences on AMR has been in the production of what is actually now a very large body of work that characterizes how antibiotics are used in practice. In terms of what kind of implications those studies have for changing antibiotic use, the implications tend to be focused on behavior. How do we change people's behavior in a particular context? And in the report, we do start off by addressing the knowledge deficit model. And this is a model that has continued and persisted as quite a dominant model for how we think about a number of different problems in relation to health over the last several decades. And the idea with this model is that we assess how much people know about a problem, we find that they don't know very much about it, and we then try and top up their knowledge in an effort to improve the situation and to change their behavior. Social scientists have, and others have demonstrated repeatedly that simply topping up people's knowledge is unlikely to be alone the most effective or even a particularly effective model for trying to change behavior, including with changing antibiotic use. What people know and what people do are often really quite different. And that's because there are many other reasons for people's behavior. So attempts to try and look at behavior differently have kind of looked quite often at what we might call an ecological model, which essentially imagines the behavior within concentric circles of other things that are happening and arrangements that affect that behavior, so that, for example, your motivation or your or incentives might impact your motivation. So the idea is that you will be making a decision about to use an antibiotic or to prescribe an antibiotic, and that there will be a number of things that influence your decision making. And these have we grouped these into ecological models and into lives and livelihood models. And if both of these kind of put a focus on the wider context, but really are still saying that the reason are focusing on why is this person choosing to do this, to take this antibiotic or to prescribe this antibiotic, and looking at layers of lots of different reasons for that. And so the focus for intervention of these kinds of studies broadly is saying that we should be changing behavior and practice by understanding and altering the context in which people are making decisions about antibiotic use. And there's a number of different ways that this can be done, thinking about different remuneration arrangements, talking about accessibility of healthcare, improving communication between prescribers and patients, providing different kinds of information about medicines, information about sensitivity of medicines, which antibiotics are working, seems to be quite an important one as well. So that information is slightly different from a knowledge deficit model. It's about an information deficit model, which places the responsibility slightly differently, not just on the individual to have better knowledge, but on a system to provide better information. Which leads us to the second grouping, which we're calling structures. This assembles the growing body of work that understands antibiotic use as a product of wider economic and political conditions. And this tries to identify the ways that antibiotics have taken on critical roles in modern societies. So we're considering here how, what kinds of interventions could target these societal structures to reduce recourse to antibiotics as a quick fix. And so when we say structures, we don't just mean physical infrastructure, we also mean the non-physical but still structural in terms of societal structures. For example, different kinds of hierarchies, but also structures such as medicalization. These are ways that society works that mean that we end up becoming, building antibiotics into societies in particular ways. And so we consider in the report different types of structures. So that includes political economy, social security, health systems, water and sanitation, and gender. And the short video we'll show in the break, I think, gives a really nice insight to this and is from this particular area where this photo is in Uganda. So the intervention here then is about modifying economic and political conditions to reduce the need for antibiotics to be used. I think for many of us, this feels really quite challenging and overwhelming as something to be changed. Can we really change politics in order to change the way that we're using antibiotics? The third section on networks is really trying to sit somewhere in between these two areas. So the behavioral and practice-based perspective comes from the idea that an individual can change what they are doing in terms of using antibiotics or prescribing antibiotics. The structural perspective imagines that we can change a much higher level and attempts to change a higher level political or economic context or social context in order to make change. That is clearly possible. We've been doing that with coronavirus in our response there. The networks section collates a more recent set of research that draws attention to some of the things that we often don't look at in social research or in other areas of research, which are the networks of logics, of classifications, of flows within which antibiotics become a part, and that dictate how antibiotics end up being used, often without really thinking about it. And so what we're trying to convey here is that there are a number of different things that, that perhaps just serendipitously end up becoming the way that we do things because it's been passed down as the way that we do things, that we need to open up for analysis to see whether we should be doing them differently. They may have quite a big impact on antibiotic use, but don't necessarily require that macro level political change, and neither do they necessarily shoulder the responsibility with the end user. So I think there's quite a lot of potential here in this more recent set of work that is kind of growing. And I think it's relevant across the whole arena from across the whole One Health spectrum. So by identifying the roles of antibiotics, which would otherwise remain hidden, we this is kind of proposing, these studies propose that we might be able to develop and pilot interventions that can build in different ways to kind of construct these global health architectures, for example, that rely less on antibiotics, which they have been doing perhaps automatically, and that we want to, the task then is to render those visible and address them. So redesigning those networks more deliberately. So the questions that arise for us in assembling all of this was, well, how do we shift from this kind of universalized, standardized approach that we're currently taking to developing and defining interventions locally? What kind of time horizon should we even be talking about when we're thinking about AMR? And what sorts of evidence should we make to understand changes that can impact antibiotic use? So we're going to talk about these next in our panel discussions. Very quickly before that, I want to draw your attention to the fact that not only do we have the report out, but for more information, we have an appendix which you can access interactively online. So here you can sort by the countries that it's located in, the human, animal, different kinds of setting, different kinds of methodology, so that you can then pull out, and I think we have in here, there's 109 social research studies listed, and in each of them, Alice has summarized the findings and extracted the recommendations of each of those studies, and she's done an amazing job with that. We also have the panel recordings. I would encourage you to look at those if you haven't, and you are interested in more detail. And another online resource which has just come online this week is from another member of our team, Anna Peris. She has put together an antibiotic use tracker, which at the moment has 270 studies. This is to look at how much antibiotic is being used in different places. The other one is for social research on antibiotics. This is count information, how much antibiotics is being used in different places, and you can again sort these by countries and by whether the type of population. This has been done through systematic searches of data, so this should save you a lot of time if you were trying to look at what's the latest in your particular setting. Finally, do have a look on this website if you're interested in more reading. We've got an essential reading section and short summaries of different readings and why they matter for AMR. So thank you very much. That's everything from me. And I'm going to pass over straight away to Heidi Hopkins to chair our next session, or I'm going to do a quick introduction of our speakers and then pass to Heidi. I'm going to do this by stopping sharing my screen and letting, sorry, how do I stop sharing the screen? Stop sharing, and I'm going to let Rachel put up our first panelists as I introduce them. So for our first roundtable, we have Dr. Hung Nguyen from ILRI, the International Livestock Research Institute. He's the co-leader of Animal and Human Health Programme, and was previously the regional representative for East and Southeast Asia at ILRI. His research focuses on the link between health and agriculture, food safety, and infectious and zoonotic diseases, with an emphasis on the use of risk assessment for food safety management with an integrative approach. Professor Iruka Okeke is from the University of Ibadan. She's a professor of pharmaceutical microbiology, and she is a bacterial geneticist researching molecular epidemiology, pathogenesis, and drug resistance of enteric bacteria. And her current research is centered on identifying potential drug compounds against bacterial disease and working on low-cost technology solutions to monitor antimicrobial resistance in low-income settings. And if you haven't read it, read her book, it's amazing. Dr. Tim Jinx is the head of drug-resistant infections priority program at the Wellcome Trust. And he leads their strategic plan to address antimicrobial resistance. You may have seen their new report on their plans for AMR coming out last year. Previously, he was in Wellcome's Innovations Division and was responsible for a portfolio of over a dozen early stage product development projects, including therapeutics, diagnostics and devices spanning across therapeutic areas, such as infectious diseases and oncology. And his scientific background is a chemist turned molecular biologist. And finally, Sabiha Esak is South African Research Chair in Antibiotic Resistance and One Health. She's a professor of pharmaceutical sciences, the director of the Antimicrobial Research Unit at the University of KwaZulu-Natal, and seems to have an enormous range of different research expertise that she puts into practice with really interesting research in South Africa and elsewhere. And that's our 4 panelists for this first panel, and they're being, and it's all being chaired by Heidi Hopkins, who is an infectious diseases researcher at the London School of Hygiene and Tropical Medicine, and has been our clinical and veterinary sciences lead at the Antimicrobial Resistance Centre since we set up in 2016. Over to you, Heidi.
Thank you very much, Claire, for that tour de force introduction and review of the report. It's very exciting, and it's a great pleasure to get to chair a panel of very knowledgeable colleagues this morning or this afternoon or this evening, as it may be in your part of the world. So without further ado, I'd like to hand over to our panelists. Each one is going to give us a couple minutes of reflection on the report and what its implications are for research. And then we're going to roll through again and discuss a few key questions. So I'd like to lead off with Professor Iruka Okeke.
Hello, good afternoon or good day, depending on where you are. I really want to thank Amis for having me on. It's been a fabulous report. I think we're really privileged to have an early look at it, and I encourage everybody to read it after the panel. So I think that the really important takeaway message for me was that antimicrobial resistance will not be solved by just telling people about it. I think this is an important part of the AMR response, but it is a lot more effort needs to go into other interventions. We need to change the convenient and systematic view that antimicrobial resistance arises from a lack of knowledge or lack of awareness alone. You know, antimicrobial resistance is a common use problem. And I suppose the, you know, the tragedy of the commons paradigm that was put forward by Harding did say that the very first thing that you have to do to resolve a tragedy of the commons is you need to have a recognition of necessity. But he did not stop there. And I think we do stop there. I think we need to think about, you know, what to do when there is a recognition of necessity. And I think one of the really nice things about the report is that it's solution focused. So if, like me, you're a scientist and you're worried that it's going to be, you know, a huge heap of anthropology theory, it's very readable, very accessible, and it actually has some really nice ideas about what to do about the problem. And, you know, we have a lot of tools that have been shown in experimental situations to be able to do something about resistance. I think one of the things the report emphasizes is the need to place these tools in a context in which they can work. That, you know, it's not enough to just have diagnostic tests and infection control committees and so on. You have to make sure that the context, that the milieu in which these tools are expected to work is actually there. And if it's not there, you could end up seeing some problems. And then the other nice thing that comes out of the report is that, you know, many of these tools that we know could impact resistance, you know, diagnostic testing, for example, or water and sanitation improvements, they have the potential to impact disease in general. And so I think the way the report is framed allows us to add antimicrobial resistance on to the potential benefits of these sort of non-resistance interventions that could impact other things, and then hopefully push them as well. So I'd like to, you know, stop there and say that it's a really great report. And I think the last thing I read that actually made me think this way and think, was actually Susan Reynolds White's The Social Lives of Medicine. It's really great to have social scientists working in this space. I think scientists occasionally dabble in social science research, and it really ends at those knowledge, attitudes, and practices studies that the report appreciates, that says that, you know, we have to move beyond this. So thanks so much for the opportunity to read it and to talk on this panel.
Fantastic. Thanks for kicking us off, Iruka. Let's go next, please, to Dr. Tim Jinx from the Wellcome Trust.
Great. Thank you very much for inviting me to participate in this panel, and congratulations to Professors Chandler and Thompson for the launch of the report, bringing this together, as well as everyone involved in contributing to this. I think it's very timely and will be important. Professor Okeke has already pointed out that the situation with AMR is a classic example of the tragedy of the commons. And, you know, as a problem that is driven by the actions of people, we have not yet gotten to the point of identifying the full suite of solutions that will be necessary to achieve a robust and sustained improvement so that drug-resistant infections are not a long-term threat to people's health throughout everything. So, you know, with this report, I think it's very useful because it brings social sciences into the research piece much more clearly. It should help to make things more actionable at the end of the day. Something that I think is critically important is the focus on local action. Ultimately, everything that has to happen here will be about local action. While we might start with a global framework and global perspectives on things, ultimately, real solutions are only delivered locally. So how do we get there? And raising those important questions, I think, is necessary for us to consider at this point in time. Very importantly, as well, is where do we focus? The AMR problem is one that is riddled with complexity. We all struggle with this burden of complexity. What we need to do is render that into the merely complicated. So how can we frame things and break them down in a way that, yes, there's a lot of information that needs to be gathered and understood and analyzed, but how do we then put that into a frame of actions that can be achieved? Ultimately, this is about prioritization. We need to achieve prioritization of where efforts are focused, both from a research perspective, but the research that informs the actions and activities that happens. And I think the report starts to make it much clearer that there are areas that need to be prioritized on this front. Now, there's some highlights for me, particularly around behavior change, that difficult beast that at a high level, everyone agrees it's important. But in practice, we know it's extremely difficult. And in this space, there's not enough clarity really about whose actions are to change, in what ways, and what are the appropriate interventions to achieve those sought for changes in behaviors. And also it gets mixed up with awareness raising and what is the purpose of that. I think the report is helping bringing a better understanding of what the issues and challenges are and positions things to change for the better. You know, I want to say that awareness raising is very important for about mobilizing the action in the first place. And Professor Okeke, I think, pointed to that as well. Is there really a problem that everyone agrees needs to be addressed? That raising awareness around that is an important thing. Is there a mandate for change? And let's separate that around changing individuals' behaviors for the good in antibiotic use. Lastly, I just want to say that this new framing, I think, will be very helpful in separating out where interventions might best happen and how they can achieve. AMR is a biological phenomenon. It's about infectious diseases, but it sits in a much broader context in terms of society, health, and other activities. And we need to tie that across so that there is a better understanding of both the AMR specific interventions and the AMR sensitive ones, so that there is a clear mobilization of actions that can achieve impact and that we're not keeping AMR in a very narrow bubble. So the new framing, I think, will help us get there better. Thank you.
Fantastic. A lot of good ideas coming in. Thank you, Tim. Let's go right on to Professor Sylvia Esak in KwaZulu-Natal, South Africa.
Thank you very much. And again, congratulations on this outstanding report. I believe that the strength of this report lies in its holistic, bio-socioeconomic political approach to addressing antibiotic use, and specifically how human behavior, decision-making, governance, and logistics determine antibiotic use practices, structures, networks, and systems, aspects that are under-researched in our efforts to contain antimicrobial resistance. I particularly like the precarity aspect of it. It highlights how precariousness at different levels affects antibiotic use, the precariousness of the social determinants of health and wellness, the precariousness and dysfunctionality of human, animal, and environmental health systems, and the precariousness of governance lacking enforcement capabilities in the face of perverse incentives and corruption. Highlighting all of these as research gaps in our efforts to reduce antimicrobial use and resistance. I particularly want to commend three aspects. First, the acknowledged discomfort of research conducted in and by the global north to address ABU challenges in the global south. Second, the conscious move away from the deficit model. And thirdly, the centrality of the local context. This will be welcomed and really well received by both social scientists and other AMR researchers in the global south. Thank you.
Great. Thank you very much, Sabia. Let's go right on then to Dr. Hung Nguyen with ILRI in Vietnam.
Hello, everyone. Thank you very much for involving me in this panel. As non-social scientist, I'm very happy to be part of this roundtable to read some comment on this newly released report. And I congratulate you, Professor Chandler, and the team for this nice report. I have to say also that from INRI at CGIAR, we are very happy also to work with London School on the AMR CGIAR hub that we developed for the last 2 years together with other partners. And some of these social research questions have been also addressed in this joint hub between CGIAR and other institutions. I have to say that, you know, I read the report with a lot of interest and pleasure. And the homework I did is, in fact, you know, when I look at the literature at the moment, when you type AMR or antibiotic resistant, you found something between 200,000 to 300,000 references. And last year, 2019 or 2 years ago, you found something like 13,000 to 18,000 papers on the topics. And here the report shows that in 2019, you found something like 200 papers or publications on social science on AMR research. So we show very clearly timely that topics of AMR and AMU in social science need really to be done more to you know, reflect the landscape of AMR from social science. You have a lot of things going on AMR and AMU, and I like the context you put this under the One Health concept, the One Health aspect of AMR and AMU. You know, obviously from the group, and when I look at the list of author and the contents, I got the feeling that, you know, you goes more on the public health side, and I wish to have, you know, a more substantial components on animal health and livestock in this report. I hope that we can come back to that in the discussion. But this is a very interesting report. When you look at the local context and you mentioned the locally adapted interventions, we are not there yet, but my understanding is, in fact, you know, together with the technical intervention to reduce AMR and AMU, both in the human and animal side, the social research knowledge need to be accompanying this technical intervention to really, this thing can be accepted and practiced in different communities. We work more on the developing country context. I used to be based, I was based long time in Vietnam, and now I moved to INRI in Nairobi. But the developing context, both in Asia and Africa, share a lot of similarities. And I think that, you know, the social science addressing AMR need to be really strengthened. You talked about the intervention, but you talk also about different type of structures and also the networks. And I think that, you know, all these factors wouldn't be considered, should be considered seriously when people design the interventions to reduce AMR and AMU in future. So maybe I stop there, and I'm happy to come back to some of this issue in the next round of questions. Thank you.
Thank you very much, Dr. Hung. We've got questions coming into the Q&A. I think we're going to hold audience questions until after the second session, if that's okay with everyone. But we do have a couple of questions that we'd like to ask our panelists now to add on to their original thoughts. And most of you have touched on these a bit. But for example, something raised in the report that you've highlighted is the need for local interventions. And a question comes to mind, I think all of us would agree with that and recognize that. But how can research, design, and infrastructure, how can research support the need for those locally relevant interventions? And since we're on Zoom and not in a nice round table, maybe we just go in the same order again. And I hand over to Professor Okeke to start, please.
Yeah, I think it's really important to have social scientists involved in the design of these intervention studies. I know quite a few colleagues in the social sciences working on things that are, relevant to health in Africa, and antimicrobial resistance included. I know very few working here with me in Nigeria. It's not to say we don't have social scientists. They're here, they're just working on what they would consider more interesting problems. And so I think we have to do a better job with recruiting them because we need their expertise. There have been efforts to do, some studies on antimicrobial use. They end up being largely descriptive. And to design a robust intervention study, I think this really needs social science expertise. And I'd like to see that social science expertise coming locally. I know our colleagues all over the world are actually very happy to help, but it's it's easier to work with somebody who understands the local context and works in the local context. So I think we really have to motivate our colleagues. And I think this is one of the things that this report can do. I think now I have something to hand to people and say, this is an important problem. You're a sociologist or anthropologist. You should be considering either working in this area or advertising it to your students. So I think that is really critical. And around this, obviously, we do need more scientific effort locally as well. We do have scientists working locally on antimicrobial resistance and antimicrobial use, but again, not enough of them. But I think expertise is going to be key. I think, having people with the right skills who are interested in the problem working locally is going to be important to get at those local context-specific solutions, which is what we really want.
Thank you, Eruka. Yes, as a clinical researcher myself, I could not agree more. And as you say, having that local knowledge of the context can't be overemphasized. Tim, what are your thoughts on that question?
Yes, thank you. So as we look at the many things that ought to be done in this space, it's very clear that there should be country-led action in this space. And in order to achieve that, of course, countries not only need to recognize the urgency of the problem, but they need to understand the problem relevant to the circumstances that they have and identify solutions and interventions that deliver useful results at the end of the day. So there is a need for local research that informs what are the appropriate interventions that can deliver real results that are of a benefit to local communities at the end of the efforts that are made. At the moment, we have a huge vacuum, which is, it's a little bit top down. Understandably, that's where we are right now. It's not that it's the wrong thing, but where do we go next? How does national action actually emerge from these top level guidance that's coming from WHO and other places? There needs to be a better understanding of the relevance of the situation locally and identifying solutions that can deliver results that actually are counted as a good benefit to a local community. This is much more than a microbiological problem of bugs that are resistant or not resistant, and it's necessary to broaden the perspective and understanding both from the expertise that's inputting into this, as well as what are the right interventions overall. Just to reinforce again, so much of this has been driven by the global north. and there is a move to better engage the Global South. But what we really need is Global South driven agenda here. And how do we get there so that there is an agenda that actually is driven by the Global South on this particular issue? It's a very different set of results, I think.
Yes, thank you, Tim. And that's picking up on some ideas that Sabia had brought out earlier. And over to Professor Sabia for some maybe more comments on these questions now, please.
So thank you. I couldn't agree with Tim more. That antibiotic use drives resistance is irrefutable in the biomedical model of AMR. But the causal pathway between use and resistance is influenced by the diverse political, economic, legislative, social, cultural, religious, and gendered contexts in which antibiotic use occurs. So these factors are really critical to the design and delivery of context-specific, locally relevant interventions. And this requires human capital development in implementation science or implementation research, what I like to call the how-to research. Now, there are slight nuances between implementation science and implementation research. Implementation science being defined as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and thereby improving the quality and effectiveness of health services or health systems. Implementation research, slightly differently defined as the scientific inquiry into questions concerning implementation, the act of carrying an intention into effect, which in health research may be policies, programs, and practices collectively called interventions. And implementation research is unique in that it evaluates the acceptability, adaptability, adoption, appropriateness, cost effectiveness, feasibility, and sustainability of interventions. And it includes a wide range of stakeholders from the conception of the research right up to upscaling and sustainability. And most of the implementation research is mixed methods, and it definitely requires social sciences expertise. So this type of capacity development in implementation research should be decentered, as we've mentioned before, from the global north to the global south, and ensure that all of the stakeholders, which includes the policymakers, the implementers, and the beneficiaries, are involved right from inception. Over.
Thank you very much, Sabia. Yes, from the start to the beginning, not just bringing people in after all the data are collected and asking them to help interpret it. Over to you, Hung, for some comments on these questions, please.
Yeah, I think that I would agree with the comments of our colleague previously said. I just want to add that we need to recognize that from developing countries in general, we have not had enough interventions to really address this AMR and AMU issue. And we should not talk about only the local interventions, but we need really to look at the intervention from a comprehensive pictures of intervening as a deduction of AMR and AMU. And I would expect also that we should mention also the policy and regulation level in different countries. Of course, now many countries develop their own national action plan. And I would say that in many countries in this national action plan, they list different activities how to address this AMR and AMU, both in human and livestock and aquaculture side. So that is very important for the government and research institution to help the farmers. I come very much from livestock animal health side. So I would say that the solution coming from the research are not there really for them to take up in a locally acceptable way. And that is really the area that we need really to design together the research for intervention, the action research, like our colleague said, by going very much on the technical issue to address that issue, but in the same time combining with the social research. And I have to say that that is actually the missing dot, really, is the connection between the social science and the natural science usually we have when we design research. That is being improved a bit more, but I hope that will be strengthened more in future. Thank you.
Fantastic. With no intervention on my part, We are right perfectly on time, and we'll go to our 10-minute break unless any of the panelists have a specific comment that they would really want to make right now. Okay, perfectly practiced, perfectly on time. Thank you very much. Let me hand over to Claire. We're going to take a 10-minute break, and everyone please come back after at 5 minutes after the hour, but also take the opportunity to watch the film from our Amos Hub colleagues if you are having time.
Thank you, Heidi. Yep, have a nice break. We're going to put on a short film now just for your entertainment.
So I'm here in Kanyabuga village where I've been doing ethnographic research for the last 3-4 years. I have a key informant, Annette, that I've come to see, and we're going to talk about what we found in the research that we've been doing and what life is like living here in Namungo. When we started this research here in Namungo, we found that people were using antibiotics, and the ones that they were using more frequently was metronidazole, and they were using it for diarrhea. It's one of the common conditions that they have here in this area. So I'm going to be talking to Annette to give us her experience living here, working as a community health worker, as well as a resident, and then we'll have a walk around to sort of understand what the situation is like. She's going to show us the antibiotics that people commonly use here, and then tell us a little bit more about what conditions they used to treat with these antibiotics.
Bakozesa nnyo no flagile lino eddagala likola nnyo mu kuddukana eno ewaffe ne bw'oba olumu olubuto ono flagile kasita oba olumu olubuto eno ewaffe olukulumamu bw'odduka kiriniki lye bakuwa ne lino ne zino sirapu
bakozesa kujjanjaba ki?
nino eddagala lino balikozesa ku kifuba amoxicillin ono akolola bamumuwa nnyo oluusi n'abamu nga balwadde balina HIV. Lino balikozesa omukyala ng'agenze ewantu ewakyafu. Lino likozesebwa ku mabwa n'ekiddukano. Zino sirapu zikozesebwa ku baana okukolola kuba ezo endwadde ze zisinga ennyo okwetanira mu bantu baffe wano.
Naye nga gano wali ogalabyeko wano gano amadagala gano gusinga okulaba?
Kale gano nagalabako nga bwe ndi VHT naye eddagala lye basinga okukozesa lye lino. Oluzzi lwaffe luno amazzi gaali gajja bulungi nnyo naye emidumu gyatuusa ekiseera ne gizibikira. Emidumu gino esatu kati tulina omudumu gumu abantu gwe bakozesa. Ogwokubiri guleeta obuzzi butono, guno ogwokusatu go tegukyaleetera ddala. Tetumanyi kuva ku kyamazzi agasinga galina okujja mu midumu ga branchi nga gafulumira eno ebweru kati gakyasobola kujja ku midumu kuli. Abantu babonaabona okukima amazzi n'ekiseera kituuka ng'enkuba etonnya ennyingi n'ebeera ng'amazzi gajja nga ga brown.
Annette has been explaining the water problem here in Namungo is that the well is blocked, the spring well. They only have one of the pipes that is working, and even then when it's working, the water is discolored when it rains, and so that tells us there's quite a bit of contamination here, and this contributes to the rates of infection around here, like with diarrhea especially, because of the unclean water that is being used here. That is acquired, and this is one of the main water sources within this village. So I'm here at one of our public toilets in Namongo, as we previously talked about. And there's one here in my background. There are a few of those scattered around the area, but obviously they are not many enough. But they are also not free. People have to pay for them. And when they're not able to pay for them, they sometimes resort to informal toileting habits, maybe using the drainage. So I'm here to talk to one of the takers, the caretakers. Innocent is going to explain to us what exactly happens here, what of the challenges he faces, and what the costs are for running this kind of facility in this area.
Ubuzibu buriho bwakuyora toyi kino kimotoka kiyonja toyi kitusaba sente nyingi naye ruri twari tusasura 15 naye naku zino tusasura 22.
Ate kati abasasula kugikozesa bo basasula mmeka?
Basasura nusu 2 n'abaana bato babwereere.
Buli lwajja okugikozesa ezo z'abasasula. Kakati mu kulabako engeri gy'obadde wano mu Namungo mu kitundu kino, olowooza nti buli omu aba asobola okusasula ssente ezo okujja okukozesa toyi?
Bandibadde nga bayongezako bbeeyi naye ennaku zino ssente tezikyalabika nga covid yayonoona ebintu. Nga covid teyajja bandiyongeza bbeeyi.
Naye kati abo batasobola kusasula bo bakola batya?
Abatasobola kusasula waliwo bajja ne beewura bamu ne bansasula, abalala ne bagaana kunsasula kubwaza kusasula. N'abalala balima bakaba mubeera ne basibira eri mu myala.
Like Innocent has mentioned, one of the challenges here is the informal toileting that comes up when people are unable to afford the toilet facilities. And so obviously the infection rate is very high. People often have diseases like diarrhea. Like we found out when we did our survey initially, diarrhea was one of the most common illnesses here. And this is really evidenced by the toilet facilities that are in the places that are not even enough for the people, and yet they have to pay for them. I'm here at the Nashivubo channel, which is another critical point here in the informal settlement. This channel floods when it rains, especially in the rainy season. It floods and then it flows back into people's houses. On a rainy season, you can find people scooping water out of their houses to try and save their property. But also there's a lot of infection that comes from this water. People throw rubbish here. Everything from the city goes into this channel as it goes into the Lake Victoria. So there's a lot of infection that comes here, and even with the informal toileting that we saw earlier on, people actually throw everything in this channel, which then gets back into people's houses, causing a lot of infection in the community. So what we have seen here today in Kanyoga sort of represents the daily life of somebody living in Namungo. There's scarcity of toilets, and yet it has to be paid for. People cannot afford it all the time. Besides, even if they could, the toilets are closed off at a certain time and opened at a certain time. So informal toileting is inevitable. People are going to use polythene bags, use the drainage. And even with the Nashivubo channel, with the backflow of the water when it rains, ending up in people's houses means there's a lot of infection going on. And even with the contamination with the water, still there's a lot of infection. So antibiotics have become a part of everyday life here. It's inevitable to use them because of the situation in which they live. They just can't afford to not have them. They have them stored in their houses. They keep buying them for whatever infection they get. So it has just become inevitable that they continue to use antibiotics just to cope with the situation in which they live.
Hello everyone and welcome back. I hope you had a good break, and for those of you who watched the film, I hope you enjoyed it. I'm delighted to now introduce our second panel of speakers. And this is the list here, but what I'm going to do, because of being able to see everyone, is actually take this down. Let me see how I do that. Oh, look at that. That's not how to do it. Stop share. So our speakers for our second roundtable, we will start with Dr. Heidi Hopkins, who is the Director of the Antimicrobial Resistance Global Coordination and Partnership at the World Health Organization. He has extensive experience in developing global TB and HIV policies, programs, and identifying research priorities and facilitating their implementation at a global scale. And he's played a major role in designing global advocacy strategies to integrate TB prevention, care and treatment, and is now playing just an important role within antimicrobial resistance. And our second panelist, who was second on the list, forgive me, is Sujith Chandy, who is a professor of clinical pharmacology at the Christian Medical College in Vellore, India, and is a director of REACT Asia Pacific. And Dr. Chandy aims to collaborate with civil society, institutions, and policymakers through research, advocacy, and activities towards conserving and enabling access to effective antibiotics. Dr. Chandy works on various national committees on medicine use with international agencies and universities as a researcher on antibiotic use and stewardship. And we have Dr. Watipaso Kasambara, who is from the Public Health Institute of Malawi. She's the antimicrobial resistance coordinator. She is the AMR technical lead and key policy partner in the Ministry of Health. She's based at the National Microbiology Reference Laboratory in Lilongwe, and has her background in microbiology, medical microbiology, and a doctorate degree in environmental health at the University of KwaZulu-Natal in South Africa. And she's now the antimicrobial resistance coordinator at the NMRL in Lilongwe, and she's been working there for the past decade. And our fourth panelist is Dr. Frank Berth, who is senior livestock specialist in the agriculture global practice at the World Bank and the coordinator of the Livestock Global Alliance. He and the Global Alliance brings together 5 global public institutions committed to safer, fairer and more sustainable livestock. He was previously head of the Animal and Plant Health Unit at the European Food Safety Authority, and his core activity was to assess animal and plant production systems and practices with respect to primary production ecosystems and public health. And he's been very active in the AMR space, including in the World Bank's report on AMR. So thank you very much to our panel for joining us. And in this panel, we wanted to focus really on the policy implications, policy and programmatic implications of the report. In the first session, we were talking about the research implications. And here, I'd like to invite each of our speakers to give a short sort of reaction or response to the report before I pose a couple of questions to you. So I will go through the list and start with Heidi, Dr. Getten.
Thank you, Claire, for the opportunity, and also thank you also for the team and for you actually to lead, this important, area that we. In dire need in order to address, this complex issue of antimicrobial resistance. And I found the report, quite, well thought, and I think the segmentation of, the whole issue into the 3 areas is, quite important, that it gives us an opportunity actually to look our challenges through those 3, specific lenses. And one tension could be also, when we come into policy implementation and program implementation is the need for a broader public health approach, or the need for a broader, standardization, so that you can galvanize the needed financial, the needed, popular support, versus into a much more tailored, approach, or localized, approach that actually needs to be done, for a social science research intervention. And how to reconcile, this dilemma will be the greatest challenge that really needs further, thinking and further debate. Also, how, where is the middle ground in order to reconcile, these two conflicts. The other point is also, we also know one size doesn't fit for all. So I think that's also the other key issue. And one other point I would like to mention is, I have been in many negotiations and discussions, debates by, policymakers, by politicians around AMR. And AMR has always been a divisive, subject, especially when you have, different sectors engaged in the discussion. Each sector is only reflecting its own sectoral view, its own advantage. And if you talk to the, the meat producers or the traders, they only see from their own lens. If you see the public health experts, they only see it from their own lens. So where is that, the social science, the study, and really to look into these decision makers and policy makers, and also appreciate, their concern, their issues, their voice, and bring some sort of cohesive, shared vision and goal. And I think that potentially could be, something which we could, look into it in detail, really to influence and impact policy. Thank you.
That's a really, really helpful, helpful prompt. And we didn't include as much of the social science of the decision makers and policy, which tends to be in the kind of international relations zone. But there is quite a lot, actually, I think, that we could bring into this conversation. Thank you very much. So some words from Professor Chandy. Sujit.
Thank you very much. Thank you, Claire, and the team for this wonderful report, and for the privilege actually of sharing my reflections in this roundtable discussion. I must say it was a fascinating read. And, when you've worked on an area for 20 years and you see things which are now on paper now, which you've felt all along and you've seen studies in it, but put into one comprehensive report, it does really help all of us who are working on AMR in many ways. The flow and the content, especially the structural and the network issues, the practice issues, it all made sense. And I'm so glad that you covered all the three areas. From a need and purpose point of view, I think this report is going to be an essential tool, if I can put it that way, for anybody who works in AMR and anybody who wants to work in AMR, because this is in one sense only the beginning of better things to come, in my opinion. The reason is that when you look at the moon, for example, you can see the light in the moon, and we all know what this side of the moon looks like. But the darker side of the moon, very few people know what it's all about. We know, in one sense, the underside of AMR because we've been working in it, but policymakers, the public, they don't get to feel the consequences of what is being written here unless it's actually written and put out into a dissemination mode. And I think this report will be the start of that, if I can put it that way, that percolation into action on the ground. And if we're able to capture the essence of all the three areas that you've talked about, plus the political and social dimensions, which are so important in the One Health, I think we are well on our way. And I'm actually thrilled, actually, that to see this report being published and put into the World Wide Web today. Thank you very much.
Thank you very much for your kind comments on the report too. Let's turn to Washipaso, Dr. Kasambara.
Thank you so much for the opportunity to be part of the panel discussion this afternoon, but also thank you so much for the opportunity to have more experienced and professional people to discuss this emerging challenge which we have. Going through the report, it's very interestingly from an African point of view, to see that we are now starting to address the local context. That is one thing which has really stood out for me in the report, that we now need to look at how we can be able to sustain the gains and challenges which we face in our local context, so that we can have a sustainable way to minimize the consequences, but also minimize issues on antibiotic use. So this is really great, looking into context that we all have developed strategies to mitigate antimicrobial resistance, but we really focused on the global, not looking at the local. So I think time has come now where we need really to prioritize our agendas, prioritize our actions, to look at the context and also see examples among us that how can we move forward, but also move with action. One thing which has also stood out for me in the report as I read is the focus on social science. These are some things which we have not really looked at to understand the dynamics of our social determinants, because these are some of the things which have really accelerated the problem. I always look up to Sabiha. She always mentors me on how you need to focus, understand the burden inside your context, and see how you can be able to invest, put a lot of investment and resources into it. So I think this report is one of the pieces which we've seen this year, which is closely looking at how we can change our attitude, change our strategies into focus really on investment and prioritizing our focus, but also understanding the research evidence and also understanding the social sciences behind it. Thank you so much.
Thank you so much. Yes, the focus on investment, I think, is a critical thing we should come to discuss. Let's turn to Frank, Dr. Berth.
Thank you so much for the opportunity to be part of this panel, and an enormous thank for this report. This is fantastic. This is exactly, I think, what we need, and I'm glad to see that we have sort of an alignment that we need to change completely our approach to this AMR issue. And we knew that for a while, facing the failure of our systems, but now there's light at the end of the tunnel. I think that your report brings some practical, tangible elements on how to move forward, and I love that. At the bank, we started to play with this AMR thing around the way we think antimicrobials, the way we use antimicrobials, and the broader context. So we had already shifted a bit our way of thinking and approaching the issue. I think that your report brings a major step forward. This is fantastic. Thanks again very much. It shows that the time of the cookie cutter is over, and we definitely need to change our approach when we as the bank, and when we prepare investments and when we perform investments with countries. And I think that in this panel we will have a chance to elaborate a bit on that. Congratulations, and thanks again very much.
Thank you so much. Exactly. So I guess that, you know, we've got a series of questions I'd like to try and get through in the next 10-15 minutes. The first question is really about how can we, and this sort of speaks to Heidi's first sort of big challenge, how can policy and programs in reality develop and implement locally tailored or locally developed interventions, we know that in a research way, it's actually far more possible to do that because you're actually usually doing things at quite a small scale. When you're wanting to do something that's, going to run to conceivably your whole country, for example, Malawi, how do we move to a place where we're able to develop and implement locally tailored interventions, still building on the evidence base that has been produced internationally? Let's go around the same order again. So I'll come to Heidi.
Yeah, thank you. So I think, before answering this question, we need to reflect on what is actually needed, to develop policy and to implement. And basically, it boiled down into resources. It could be financial resource, it could be adequate capacity, human, technical expertise. So that availability will be the determining, factor. And that availability, that resource also goes with how the country position itself in the world, platform, whether it's middle income, low income, high income, which in a way also embrace, that part. The other ingredient is political commitment. Because if there is political commitment, of course, the politicians will make the availability of resources for this type of policy. But we don't often get the political commitment for a very divisive and potentially, area like AMR, because our politicians, oftentimes they have short-sighted because their term is also limited. It's about their election. It's about their election commitment. So I think there are all these, complex issues that we need to consider. So in that case, I think our approach also to, use evidence for locally tailored policy has to also take this into consideration. And when we look, the success from very well advanced public health programs, and I have been, as you mentioned in my introduction, working on for a long time on global TB and HIV, policies, basically really starting policies from scratch and looking into the implementation, into the real, service, the end user. So what is, basically is needed is really a framework, an approach, and also, galvanized movement, civil society, and popular support, and that acceptance, at the ground level, in the community, in the civil society, which you actually touched in your report, by looking into the practices of the different stakeholders, the different actors, and owning, in order to ensure that ownership, and also pressuring the political system, at the local level, so that whatever is generated can be used locally.
Mm-hmm. So a lot then is around the political in order to get the resources, in order to then have the action that is kind of locally required. Sujit, do you want to add on to this question of how can policy and programs develop and implement locally tailored interventions, or adding on to Heidi's points?
Thank you, Claire. I completely agree with Dr. Hailey. Well, one of the fundamental differences, if I can put it that way, between the lower middle income countries and the situation on the ground there, vis-a-vis high income countries, is that much of the culture and belief system are completely different. And the ground realities are different when it comes to affordability, when it comes to hygiene, you name it. So you have the situation where the circumstances are different. And then you have AMR, which actually sort of percolates into every sphere of life, whether it's in the ecosystem or the atmosphere or human behavior or livestock. And so when we create a policy or a program, which often looks at the science of it and looks at it from a top-down approach, let's put it that way, percolation into these kind of cultural, psychosocial milieus is very difficult. And we know that from other issues where it came to climate change, etc. And many of these macro problems, which includes AMR, therefore has to be dissected out when you look at policies from a social research aspect. And therefore, this report, if we dissect out various issues, we can actually see, it becomes a bridge between this policy is available, and this is the local context. And this bridge in the social report can be used to sort of analyze and match, will it work or not? But that's not the end of the story. The report actually is the beginning of the story. So what we'll have to do is, for all of us working here, all those listening and beyond, to look at this report and see, okay, hey, this is what works in this particular country, in this particular context, and will it work there? The second thing which is going to be important is when we do research into social science and try and match it with the actual policy and program, is to look at the challenges and the success stories and see whether that's something reflective of what our local context is. I think that's the only way that we probably can move forward with this. And I would say that if we're able to do that, and we're able to make our policymakers understand the relevance of what we're saying from the social side of things, they may be able to tweak their existing policies, not have to create entirely new policy and programs unless it absolutely is not working. That's what I feel at this point.
Thank you. And I think that the point that you start to touch on there as well, around we need, that need to look at successes and challenges, is also around the kinds of expertise that are required. And perhaps there's a place for social science, but one might argue there's a place for this implementation research, which Sabiha was talking about, in terms of that it doesn't necessarily need to have a scientific audience, but it needs to have a local policy and program maker audience where that information is being built back into systems, and that perhaps we need to be thinking more carefully about where that kind of expertise is positioned. Watipaso, would you like to add to this question of how we develop and implement locally tailored interventions?
Yes, just adding on to the two speakers who've already done a lot of work on understanding how we can tailor this through. Another thing we can look at is to understand country prioritization in implementation of AMR. We have got these documents lying around, but have our countries been able to prioritize, but also to be able to implement? Have they been able to tailor with some of the actionable programs which are highly funded, so that we can be able to leverage and tailor them together, link them with IHR, link it with sustainable development goals, link it with COVID right now, and link it with be able to link it with another, let's say, MDGs. So we should be able to have champions who can be able to support country prioritization, but also in doing that, we'll be able to have resources, but also have a proper governance system, but also have proper implementation of these policies. In many of us, low and middle income countries, we're failing to access resources because we have not yet leveraged integrated AMR into a number of programs. We have so many programs which do talk to AMR, but they are in silos. So when we reach at a point where we'll be able to have country champions who are looking at integrating even social science and bring it, because the social science will be extensively done by universities and other civil society organizations. We should be able to have a platform where these can feed back to a knowledge translation platform where government and policy makers will be able to utilize the information and move forward in our programming. Thank you so much.
That's a really, really important point about that, the integration with SDGs, the integration across, the way that AMR is this problem that is integrated with lots of things means the solutions must also be integrated. And the models that we have, this kind of off-the-shelf siloed programmings, really runs counter to the sustainable change that everybody has been mentioning. So how to build that in, given, as Heidi was saying, you've got this you know, constant turnover within the political sphere. So how does one create sustainability within that? And Frank's going to give us the solution now.
Not sure. Well, what that tells me is that we need to radically change the way we work. I think that's the comfort that we had before of bringing some sort of pre-cooked solutions and try to plug them into a national program is no longer acceptable. So spending time on context and in-depth understanding of the driving forces around AMR and all around antimicrobials and all the tensions is the first step. And usually we don't pay enough attention. We say we do, but we don't. And we often just scratch the surface, but we don't go to the bottom of things. So to take a practical example, use of antimicrobials as growth promoters in animals is a driver for antimicrobial resistance. And so very often we come with the intervention, ban the use of growth promoters. But yeah, you can ban and go dancing, but you haven't moved the needle at all. So you need to understand why people use those growth promoters. What are the feeling of the farmers about that, and how you have a way to influence that system so that effectively farmers will stop using those products. But that requires time. That requires also, I think it has been said already, the right approach, not top down but bottom up. Having the right people to perform that step. We're missing that step quite badly right now. The other thing that we need to do is once we have a better understanding, we need to plug our interventions where they are likely to success. And I think that we have to all realize that AMR standalone may be a bit difficult, and just speaking for the bank, I don't think we have any investments that is an AMR investment. So we invest in public health services, we invest in agriculture development, we invest in different things, but not in AMR or something like that. So the next thing to think about is how we integrate those tailored interventions into the broader programs and investments that are made in the countries, and how we track them. So not really a solution, but I think there's an opening on the new way of working to integrate the AMR issue into our business.
Thank you. And I think that last thing that you were just saying as well about and how we track them is incredibly important. You know, how we measure success it ends up defining how we do things. So how we make those success measures is incredibly important. And if we're saying AMR is something that has to be integrated for a number of different reasons, both practically, politically, and technically, in order to succeed, then somehow we have to look at the kinds of success measures that are also integrated, which I think is a real challenge within policy as well, given that it's kind of created, you know, these silos are already standing. So just in the last couple of minutes, I just wanted to go around and see if anybody might respond to the question of the time horizons. You know, we are all recognizing that AMR is a very big problem. What kind of time horizons should we be looking at for trying to design and scale up solutions? What kind of time horizons should we be looking at in terms of when we want to see success and measure that success? tricky question. I'm going to go around our same order and just give you the option to answer or pass. Heidi.
No, I think we are running out of time already. So I think the question of time horizon is probably is not for discussion, because this is exactly what we are also really functioning, from our perspective, especially following the IACG recommendations and implementation. And even 2 weeks ago, we established a global leaders group on antimicrobial resistance led by the prime ministers of Barbados and Bangladesh. And that was their inaugural meeting. And what they said is, we are running out of time. We should really act in sense of urgency. And I don't see that is different also for social science. Actually, social science is, for me, actually the lever to bring all these successes into consideration. And I think all what we need to do should be, either disruptive of bad practices or bad structures or bad networks, or incentivize, because the whole issue now, as Frank was trying to mention, why do farmers or growth promoters are using antibiotics? Why do politicians do not want to discuss about the use of antibiotics in growth promotion? Because it's income, it's trade, it's economic development. So how can we incentivize them, to discuss and actually to think alternative methods? So I think we are running out of time. So we need to rather focus on what needs to be done now.
Is there a scope for a shorter and then a medium-term horizon for the different kinds of, so within the structure section of the report, we're identifying really quite difficult things that are very, very difficult to change. If one focuses only on the immediate term, we will continue to do probably the practices things, because those are the easiest things. Telling people to change. But then the time keeps passing and you're still stuck in doing the practices. So I guess part of embedded in the question is, do we need to be doing multiple things concurrently with different time horizons, so that we aren't perpetually trying to just tell people to change it, but that at some point there are some structural things that get changed so that people aren't having to keep changing their behaviors. It's a little bit like the way that the vaccine stops us having to use NPIs in COVID. So are there, should we be looking at multiple time horizons, I guess?
I mean, just to quickly brief, comment on that one. I think one of the disadvantage of AMR is it's not in the Sustainable Development Goal agenda. Had it been there, 2030 will be, a proper, timeline. However, in the last year or so, we were able to manage to put an indicator on bloodstream infections as part of the Sustainable Development, indicator framework, which actually will now be part of the government's, countries' Sustainable Development Goal implementation. Hopefully, it will be approved next month by the SDG Commission. So I think that probably give us some long-term, SDG-related 10-year framework that could help us. But I totally agree with you. We need to think alternative ways of running multiple things at a time.
Thank you. Right, we've got 1 more minute for this round, so and then we're going to open up for everybody. So, Sujith, off you go.
Yeah, thank you. I agree. I mean, I think we've run out of time. We've lost many years. There's no time left. But at the same time, we have to be practical of what we can do with the limited resources, as that also impinges on time. But I think COVID has shown us that when we are desperate and we really need to get our act together as countries and at all levels, it can be done. So, but if you really look at it, lives and livelihoods matter. So whichever way you look at it, AMR, lives and livelihoods matter. If you don't do anything, lives and livelihoods matter. So if that percolates down to all levels, including at the governmental level, at the international level, and at the farmer level or just a basic public person, I think things would move much faster. But then what triggers that movement is social science will have to actually answer that. And then we move. But I feel there are so many things like hygiene, etc., which if we get the essence to the public fast, it can be done right now, and we don't have to wait. Whereas the more infrastructural issues definitely will take time. Thank you.
Yeah, Frank.
Yeah, I'm conscious of time, so I'll try to be short. I think we are in the messy situation where we're changing our way of working. So we are a bit in the workshop, and we're trying to do things. There will be essay and errors, and I think that we need to do that now. No time to wait, and then we will formalize a bit more this new way of working around AMR. But I think we have to accept this messy situation we are in right now, where we want to change the way we've been working so far. So yeah.
Thank you. A last word, Washikase, before we go to the open up.
It's very evident we do not have time. We need to prioritize on what can be done, and we can do a number of things as long as we have focus and we know what we are able to measure and achieve. So it is very possible. We have no time, even in the midst COVID, there are a number of things we have accelerated AMR, and it's very alarming right now when we just look at the data only within COVID, but we can be able to work on a number of things and be able to achieve some desired outcomes. Thank you.
Thank you very much. So now we're just going to open up to all of our panelists. So we're going to add everybody else back in, hopefully. So you need to now unmute and undo and put your videos on. Tim and Hung and Iruka. And Sabiha is on, and Heidi. Okay. Great. So we've got a couple of questions that have come in from into the group, but I just wanted to see whether there were, from the whole panel, we kind of opened up these 3 points of discussion, whether people had some additional things that they wanted to add. The first panel got a little bit less time, and I know Iruka has to go relatively soon, so I did say she could have the first opportunity to say something at this point. Do you want to add anything immediately?
I'll just say, first of all, I learned a lot from the panel. I want to thank everybody who's on it. And I'll say, in response to one of the questions that's up there that I can't quite answer, sort of what kind of machinery do we have for local interventions? Are we feeding up globally? I think that this is really a good time for this, because now that many countries either have or are writing national action plans, we now have local discussion for it. Certainly in Nigeria, there wasn't much. We knew who the AMR researchers were, but we weren't necessarily talking to each other as much as we are now, and talking to policymakers. So I think we have platforms to do things locally. Are we feeding things up globally? I think when we can, we do, but I think there's also a question of representation. There aren't that many voices from lower and middle income countries in global spaces. There are some, and I hear them shouting. So I think that this is a really good time to start thinking about local research and local solutions and owning problems and solving them locally. Thanks.
Thank you. And Sabiha, I don't know if it was a different topic or if it was an answer to the question that has arisen.
I'd like to come in on the time horizons, please, Claire, if I may.
Yes.
So for me, addressing antimicrobial use or antibiotic use and resistance is an unending marathon and not a sprint with a finish line. And this is because research has shown us how easily bacteria develop resistance on a microbiological level. We know that the vast majority of big pharma has removed themselves out of research and development. And resistance has so many confounding factors like education and public-private partnerships, etc. So to actually address it requires changes in practice, overhauling tangible and intangible structures, and optimizing networks. And all of these containment measures require context-specific interventions, and what I believe is investments in perpetuity. But obviously, this also needs to take an incremental implementation approach for especially low and middle income countries who are not quite there yet. But also, we should all work within a continuous quality improvement paradigm. Over. Thank you.
Thank you. So the pace again. Does anybody else want to add from the first roundtable about this time horizon question? Tim.
Thank you. Everything that it said, I simply want to say, yes, that's exactly right. But I want to reinforce that what we need to do is identify the sequential set of activities to be pursued. While the full containment control of AMR is a threat to human health will take a very long time, there are things that can be done today. We need to be clear in understanding what can be done today in the appropriate context to get on with doing it and start chipping away at those bigger, more difficult things that will literally take decades. So let's prioritize and think in terms of sequential improvement so that we can arrive at a point of control. Thank you.
Thank you. I think that's a really nice summary of where we've got to on the time horizon. So shall we take some of the questions from the chat? So we've had a few questions that have come in. I think, Sabiha, you have already addressed and answered live, amazing Zoom skilling, the question about implementation research. I don't know if you need to add anything else on there. We might come back to it if we need to. So we had a question from Klaas who says, over the last 80 years, antibiotic stewardship has primarily been structured by expert panels weighted towards the biomedical, behavioral, and economic sciences. Is it time to actively embed social scientists in global expert bodies? Which disciplines are we missing? I think it's happening. Heidi, do you want to comment?
No, yeah, I think it's yes, and actually we are already, incorporating. It's not only for stewardship; it's also beyond that. So I think, as I said, what are those either disruptive or incentivizing interventions that we need to incorporate? Yes, it's a good idea, and it's happening.
Thank you. Does anybody else want to comment on that? There was oh yes.
Yes, linking to that, but more broadly, I would say that, and even showing this report, a lot of things have been done on public health side, and given the quantity of antibiotics used in livestock and aquaculture, and now plant also sectors, 70% versus 30%, I think that we need to do more to understand how this antibiotics is used in agriculture sectors. And what is missing here, I think that we need to involve more colleagues from anthropology disciplines to work to really understand the driver of the use of antibiotics and how they understand that. I think that Frank shortly mentioned that in his comment before, but I just want to share that, from some of the study we show in Vietnam, in pig production sectors, people use antibiotics to mix with the feed in the past. And when we send our master student asking them for the first 2 days, everyone said, "Oh, I didn't put any antibiotics," etc. And when our students stay with them for 2 weeks, and after 10 days, they said that people really tell the truth. And that is the thing happening at the moment. I hope that much less now with the on this regulation, etc. But I think that is really crucial to understand on this network and drivers. And finally, the intervention in terms of timeline and the local context. I have to tell you that we need to consider the incentive to really push our farmers to change their behaviors. Why they have to change when is accessibility to antibiotic is so easy and is so cheap. So I think that we need really to combine really the solution that we need to develop for this community of farmers, combine with the regulation. And if you really want to scale it, the incentive is key in combination with the regulation of the country. I'm happy to hear another colleague mentions the National Action Plan. It's very nice to have on this National Action Plan. It looks very similar in one country to another, but really in the implementation of this National Action Plan and the reinforcement of the country have to go along with innovation in terms of intervention and solution we propose to farmers. I'm from the livestock side, like Frank, and I think that we need really to promote a little bit more on the agriculture side to really solve this global problem of AMR. Thank you.
Thank you. And I think, you know, that dovetails with a couple of the other, oh, sorry, carry on. You want to? That dovetails with a couple of the other questions, which I think have been around, you know, what is the role of the social sciences in these different spaces? And I think I would say as a social scientist also that it's not always for the social scientists to do a lot of this work. I mean, we may be, and I really like the way that Wachipaso was talking about, you know, platforms for engagement with people who have research expertise. But, you know, we need to have people embedded within systems that are monitoring what's, you know, what their activities are doing. They don't even have to be interventions per se, but what the activities are, and knowing and having the skill sets to monitor impacts, you know, across different arenas, and the ability to tweak and change that kind of implementation science that Sabiha's talking about. I think this is not necessarily something we need academic social scientists to take on. This can be things that we need to be equipping people within, you know, our health research or our health professions and people who are built into local health systems. So I guess it's a question to the panel: how do we support that when we are thinking about, you know, what we want to push for in terms of investment in AMR? Is it investment in a lot more research that gives us lots of evidence, or is it investment in systems that can help produce its own evidence? And what would that look like? I gave you the answer, sorry. Frank has unmuted.
I think I would go for the second option. I think when you look at the evidence available, there's a lot of evidence around, and what we see as a major gap is clearly implementation. So if we go for massive investments now, it's really on this gap and the implementation gap. So not saying we don't need more money for research, of course. I mean, we do. But clearly we've got a lot already to make a dent on the situation on the ground. So yeah.
I you know, if you allow, I would add to that actually, you see, if you talked about research, I think that in this area we should go more on the action research direction rather than, you know, generating more evidence on AMR. Because if you look around, you know, we know that this already is an important topics, and so what we can do to solve this problem. So, you know, if you take about research have a role in addressing this issue by doing more action research, but not, you know, really, you know, data generation.
So Clara, briefly on that, I think this dichotomization probably is not good. I think we need implementation and we need research. We need implementation research, we need basic research. We don't have antibiotics, we need expanded, you know, research for antibiotics, alternatives for antibiotics. So I think what we need is actually, what is the source of the finance? What is that investment? How can we be innovative? I think that is what we need to discuss. Otherwise, you know, the integration of AMR into the different sectors was discussed earlier. Yes, it's a good idea. And that is what we have been doing for 5 years. But if you go and see, out of the 130 plus national action plans, it's only 20% that have put financing, because the anticipation is, yeah, we will mainstream it into this sector, into that sector. So in this, there will be no owner. So I think that is why we need to actually really prioritize the need for financing, and that financing has to be for all essentials. Research is essential, implementation is essential.
Mm-hmm, mm-hmm. And indeed that financing for for being able to create that integrated approach is a platform in itself for things way beyond AMR. It's something that we know is a wider conversation about how, as Tim put it earlier, how the global south can be making this happen rather than us making it happen to people. Does anybody else have oh, hang on. No, there weren't any new ones. There was one about gender. I'm just going to tell you to read the report because there's a section in the report on it. Tim.
Yeah, if I could, I'd like to build on the previous comments, though. You know, as we look at AMR, it's a real issue about public health. While it crosses over into sector spaces, geographies in numerous ways, the reason we need to address this is the impacts of public health. And something I've learned as a result of COVID, a little bit naive of me, is that public health is a completely political sphere. And one of the things that I think we are struggling with in the AMR space is the politics of matters and the political engagement. So we necessarily, from a science and research perspective, should generate evidence. But we need to better understand evidence to inform decisions and position information to decision makers who will make invariably political decisions in this space. So one of the areas I think we have a significant gap is understanding the needs of the decision makers in this space. And I think social science is very important here. And what was raised earlier, the social determinants, I think, are critically important. We have to move away from this being simply a techno-medical problem and beyond, and be able to address the social determinants so that it is clear that there is a reason to act and that mobilizing energies, efforts, and monies can deliver useful results. So I mean, Heidi raised the question, it's always the case. Everybody wants more money for everything. So that's nothing new. How do we move beyond that, let's get money in this space, to creating a dialogue about delivering things that make a difference? And we aren't doing a good enough job there. So there's more work that needs to be done to cross this gap between evidence, information understanding, and decisions that decision makers make in a political sphere. Over.
I think that's a really, really great summary. Thank you, Tim, because I think that brings us to really what we wanted to achieve with the report, which is to say these are much bigger sets of problems, and that by addressing them through AMR, we're addressing other things as well. But also, you know, the AMR as a problem and antibiotic use as a problem it is a political problem. And how does one address that? We you know, I think there is a necessary gap, as you say, still in the research about how we do that. But I think in addition, it's not just a research gap, it's a gap that we need to be addressing collectively. And one of the fantastic things I think I've felt since being involved in AMR as a research area is the community of practice between research, practice, you know, people working in policy is amazing. I think AMR is it's an incredible group of people who are trying to tackle this problem. And so I'm looking forward to being able to find some of the solutions, and maybe in 5 years we'll have another meeting and it will all be solved, who knows. But can I say a big thank you to all of our panelists today for joining and for sharing your really, really interesting insights and responses to the social science report that we prepared. It was really so interesting. I learned a lot. I've taken lots of notes as well. And I'm sure all of our participants have learned a lot as well. Thank you very much to everybody who came along to join. It was great to have such a big show of people, and nice to see all your pin dropping all over the map at the beginning. Thank you very much to Rachel Ford and Jenny Westad for arranging everything with this. You did an amazing job. A huge thank you to Alice Thompson, who really took the lead on writing a lot of this report and really engaged well with lots of different people, getting lots of inputs. Everybody knows how challenging it is when you have 31 different people commenting on your work. And she's done a really great job in a short time. Thank you very much to Heidi for helping with the panel. Thank you to Alex for doing the illustrations, which we will look forward to. And so from here, please keep in touch. Use the hashtag SOXIAMR to keep it together, and we will look forward to seeing your responses. Enjoy the report and have a good rest of your days. Thank you very much, everybody. Goodbye.